Sup, guys? Welcome to the PT Good podcast, where we talk all things ortho, from physical therapy to training. My name's Kane.
And I'm Mark.
So, Mark, what is on the agenda for today?
All right, Kane. What we're looking to talk about today is going to be follow-up appointments and what the reassessments look like at these follow-ups. We talked about treatment and developing an initial plan and program at the evaluation in the previous episode. Today, we're going to look at what the follow-ups look like, what kind of questions you're asking, the information you're looking to get from these questions, and how that information dictates what you're doing with your plan of care going forward. So, Kane, let's say, you go ahead.
I was just going to ask real quick. When you go from your eval to your first follow-up, do you expect there to be big changes like right away? Do you expect them to be very similar as to how they presented?
Yeah, it seems to be. I mean, certainly it's dependent on the patient, but if I'm getting a real clear answer, a real clear response at the evaluation, unless something changed, unless I wasn't clear about the exercise, the dosage, or something else happened, I expect at least a similar response, right? I mean, I don't think I expect it to be worse unless, like I said, something happened. So if someone does come in and let's say they had like a, 50% reduction in pain at their evaluation with a certain movement, I don't expect them to come back and be like, hey, actually, those same kind of symptoms have spread or they're worse, or, now I've developed, numbness or weakness in my foot. If I do get that kind of response, it just gives me some more information that leads me to think that other questions I have to ask, maybe I have to look somewhere different, or, maybe if it's something that's very severe, maybe even a referral at that point. But if it's your standard kind of presentation, good response at the eval, I do expect that to carry forward in the follow-up. And if it doesn't, it's okay. It's just, some more information we can work. Okay, do you find that you have a similar experience? Do you find that, it's a little hit or miss if you're getting even if you're getting a good response at the eval? What do you see in your experience?
So I think it depends on how the eval initially goes. So my eval for the most part is for spine, actually for most things, like we talked about before. I'm trying to find that comparable sign. I'm trying to establish baselines. That is my main priority. I give them a quick exercise or two for their primary deficit, and then we kind of go along from there. I do not have all of the things that I need to be able to make all the correct decisions right off from the eval. That's just not my style. Maybe I'm not that fast or efficient or good enough yet, but it's just one of those things where it's like, I want to make sure I have all the things that I need to make sure that I can make those decisions going down the road. Sure. So a lot of the patients that I see are going to be one of two things. A, I found their comparable sign. I know what their primary deficit is. We've nailed it. We've made significant changes in the clinic, and then they're able to do it at home. They come back in, they're like, I feel 50 to 75% better, if not more. Awesome. Like, those are the home runs, essentially. Everything is pretty much clear cut. You know exactly what you need to do from eval and moving forward. That case is done.
Okay.
On the other hand, I usually get a lot of these in my experience where it takes a couple more sessions where it's like, on eval, I can't make those significant changes yet. I have your baselines. I have a couple of comparable signs. Cannot truly determine whether or not that I'm on the right track based off of the test-retest method yet. Sure. It's just kind of telling me things have not changed. They've stayed relatively the same. And how are we going to pivot from here? Or how do we continue to proceed from there on out with that? So on first follow-up, it is not uncommon for me to check in with a patient and they're just like, I feel about the same. And I'm like, okay, that's cool. There's just it's not unexpected.
Now, do you ask any, when you have a patient come in and tell you that, and they're telling you it's the same, what kind of follow-up questions do you have for them in regards to that word same?
So I will usually ask them like, okay, so were you able to keep up with your exercise? I really emphasize that. And it depends on the structure that's involved. If it's their spine, I am like 100% on them about like what they're doing at home. Like, how are you doing your exercises? Show me what it looks like. How often are you doing them? And I make them tell me their sets, their reps, their frequency, etc. Are you consistent with it? And are you doing it and comparing it to other baselines? Like, did you do a provocative activity? Did something change? Did you do your exercise before or after? Did that change anything? I am way more in the nitty gritty when I can find if it's spine or if it's like if I can find a directional preference. But if it's any other joint, less so. I'm kind of like, okay, did you keep up with your exercise? And when you say the same, what exactly do you mean? Do you mean it's the same exact pain, same location, same frequency, same duration, same intensity, everything? So I'll run through that list with them.
Which is certainly important, right? I mean, you could have someone come in and maybe intensity is the same, but maybe they're feeling it 80% less frequently. Oh, my pain's the same, right? Unless you're asking these, I mean, completely different information they're giving you. I mean, they're answering your question, but if they're telling you it's 80% less frequent, but the intensity is the same, a little bit different than it's the same. The frequency is the same, the location is the same, the intensity is the same, right? I mean, it changes your management going forward. If you hadn't asked those questions, you wouldn't know.
For sure. So, like, are there any other questions that you would typically ask, or are you surprised when a patient comes in and they're like, no, I feel about the same, and like actually the same, nothing has changed? What do you typically do in those cases?
Yeah. So, I mean, I think if someone comes in and they're truly the same, I don't know how you feel about this. To me, that's almost, I would prefer them to say obviously better, or even I would also prefer them to say worse rather than the same, right? If they're the same, it means, okay, they came in for a single valuation. We made a difference there, but we didn't have a lasting response, and it's not changing in any way, right? The amount of patients that come in and are truly exactly the same, I find is less, especially when I start asking the questions that you talked about. Okay. So I usually start with, they come in, hey, symptoms are about the same. Okay. Where are you feeling it? So let's say I had someone come in, cervical spine, radicular symptoms down to their hand. If I ask them how their symptoms are, maybe they're going to tell me about their spine symptoms, right? Maybe that was more painful in the beginning. So in their head, they're focusing on that. If I don't ask them the location, I don't know, right? Maybe they've centralized from the eval to when I'm seeing them for the follow-up. Perfect. Even if they have more pain in their spine, right? We can work with that initially. So I'm always asking location first. Secondly is about the intensity, right? Okay, so you told me it's the same. You're still feeling the same amount. Okay, yeah, sure. Thirdly is going to be about the frequency and the times when they're feeling it, right? So maybe the intensity is the same, but maybe, you know what, actually, like the last couple of days at work when I would reach overhead, there was a couple times where I didn't feel it. Oh, at the eval, you told me you would feel it every single time you did that, and we tested it. So we're getting a lot of different information there, right? Typically patients, even if they have that information, it's not that they're necessarily hiding it from you. They're giving you the response that they think you're looking for when you ask, okay, how are you feeling? How are your symptoms, right? But unless you ask them more specifically about it, you're not going to get the right information typically. So I always ask location, intensity, and then the frequency of the symptoms, if they were at rest or in regards to any kind of certain specific instances that were provoking or increasing these symptoms. Yeah, so those three things I'm definitely asking about.
I think it's interesting because like I've definitely started asking a lot more about their function, and this isn't just for like first follow up, but like just in general, where I will ask them, what are some things that you're able to do now
Sure,
that you weren't
sure.
able to do previously? Or what are some things that are still giving you
Yeah.
issues, or that you've tried now and you're, this I can do, and
yeah.
I thought it would give me trouble, but I don't have any issues with it, versus like, oh, I'm trying this again and I can do it now, but it still gives me some problems.
So will
And
you,
that gives me a whole lot of insight.
yeah, and will you ask that to someone who has told you that their symptoms are the same, or are you asking this to someone at their first follow up after eval, or do you work that kind of questioning in soon? Do you work it in a little longer down the line when you know they have improved, just to kind of reinforce that thought?
It's a little bit more down the
Yeah,
line
sure,
when I'm
sure,
like,
sure.
okay,
Yeah.
I think we're seeing improvements
Mhm.
clinically, but some patients just don't seem to see
Yeah,
that or
yeah,
notice
yeah,
it when they're at home. So that way you can start to plant that seed,
yeah,
and
yeah,
then you bring it up to them, and they start to become more and more aware of it, and they're like, oh, I am getting better. I can do
yeah,
this. I
yeah,
can do that. And it's like it encourages them to actually continue testing out that
yep,
body
yep, yep,
part
yep, yep.
to see if it's getting better, if they can tolerate more. And then that is just so empowering for them, and it just makes your job so much easier because they just supply you with all the data that you
Yeah.
need,
So then
really.
next time they come in, they're like, "Hey, actually, we talked about it last time, like how sometimes it doesn't hurt when I, pick something off the ground. And actually, since last week, I've noticed it didn't hurt me at all. Oh, perfect, right? You don't have to ask anymore. Now they're giving you the information. One thing I like that you said too is um, how you'll get patients that they're improving clinically, as you said. It's a kind of wording that I use too. It's like, hey, especially in maybe people who aren't responding as quickly, but you can see that they're improving from a clinical standpoint. You um, I usually use wording like, okay, so I just want from my point of view, your range of motion's improving, your strength is improving, mobility is improving, right? I can see and I can test out that things are getting better. Where do you think you're at? Are there things like, and we can use the kind of questioning or phrasing that you use. Are there things that you couldn't do or were difficult for you to do before that you're doing now? I like the wording because it brings it together versus, or sorry, gets the patient involved, and you also are able to provide your clinical expertise and explain to them how you can see they're improving. But then you get their point of view as well. Versus, if we bust the goniometer out or we get the dynamometer or anything, and we're like, oh, this says you're better, right? It's kind of, the wording certainly matters. And when it comes to the follow up and the reassessment, I think it's important that you're approaching the patient's issue, as a team.
Yeah, and I think there's I forget what exactly that stat is called,
Mhm.
but it's the minimally like detectable
Yeah,
change
yeah,
that is
MDSC.
still that's
Yeah,
relevant to your patient. That is like, I think that is so important, because the degrees on a goni do not really matter
yeah,
in regards to that. So it's just like, what is important to you, the patient, what is salient to them, and making sure that we incorporate their goals into their
yeah,
treatment
yeah,
and stuff like that. That is, like, to me, how I can really determine if someone is getting better or not. Like, they will tell you that they're getting better.
yeah.
I should not have to convince them, for the most
No,
part.
there shouldn't
And
be. Yeah, exactly. Like we talked last time, right? It's or maybe even the not the last episode, the one previous. Like the change should be obvious. We shouldn't be having to convince anyone that things are improving. It should be the patient should realize it, and they should be able to relay that information to you.
yeah, I feel like if I have to sell you on the fact
Yeah,
that you're getting better, we're grasping at
yeah, yeah,
straws. And
yeah.
it's the
It's just
same
not.
way. And I feel like this is something that we both utilize, which
Mhm.
is like when we apply an intervention, we test retest. If something is especially for spine, and we're trying to determine a directional preference, if it's a little bit better, if it's a little bit worse, if it stays the same, those three mean the same thing to me.
Yeah, yeah,
They do not really change much. If we're talking about a tissue, it might change a little bit more. Sure, there could be a little bit more leeway there, but those three, if the patient
Yeah.
is having a hard time selling me on their symptomatic response, I am for sure not going to believe that.
Yeah.
But
It's always good. Yeah, good.
If the patient tells me they feel better, then that for sure, like that they're like, oh, I could do this. I could do that before. That to me is like, dude, you already did all my work for me.
Good job.
You proved it to yourself.
Yeah, it's always good when you're at the eval, you're testing your movements out, looking for, okay, how's it feel after? How'd it feel during rub? And they kind of, eyes squint, head kind of tilts back and forth. Yeah, maybe actually, I think it feels a little bit better. No, or we're going to say that you clarify it for them and you say, okay, listen, if it's a little bit better, we're saying that's the same. And then they're kind of like, okay, yeah, it is about the same. They're kind of, maybe they're just a nice person. They want it to be better, right? Especially in the beginning of my career, I kind of rolled with that. Like, oh, good, it's a little bit better. We're going to keep doing it. I can't think of maybe count on my hands the amount of people who were a little bit better at the eval, who had come back and been a lot better at the follow-up, right? It's just doesn't seem to add up, or doesn't seem to carry over. Yeah.
It's definitely not a common trend. I will see it on occasion where it's like, if we speak about spines in particular, where they just need the volume and frequency. At that point, it's not even like a directional preference. It's usually just a mobility issue. So it's like, we just get you moving, and you do it a couple of times, you're going to feel better.
Oh, that sounds like directional preference to me, man. Come on. I gotta bash it.
So, I mean, okay. If it's a little bit better, right? If it's a little better each time, to me, that's not a directional preference.
Yeah,
I would just say it's a mobility deficit. You do it, it gets better. If you want to classify it as that, that's cool. That's fine. But to me, directional preference is like a significant and rapid change in symptoms.
Yeah. So about what's the what do the patients look like that do need more time? You find their clinical presentation at the evaluation, or their response to the initial treatment at the follow-up is noticeably different compared to those who do respond quickly? Like, have you noticed any specific, clinical trends in a population that, you can tell that they have a positive prognosis based on the evaluation, but maybe you just think they need more time?
Sure. So, that usually what I'll find is, I'll usually put patients into like a couple of buckets for me.
Yeah, sure.
The first patient is, okay, I have your baselines, I have your comparables. We made significant change on eval. They're in and out. I'd say 5 visits tops.
Yeah. Okay.
Usually I can get them in and out in 2 to 3 visits.
Those people you know at the eval, and they come and you're like, yeah, I'm better. Okay. You expected that. That's the first bucket.
It's not, maybe it's a textbook presentation, but you're just getting the rapid changes that you would expect to see. And you're like, boom, done. We don't have to worry about this anymore.
Yeah.
There are other patients in the second bucket where you know what it is, but you cannot make those rapid changes.
Okay.
You know it is going to take time, or that you may not be able to treat them. You still know what's going on, but it doesn't necessarily mean that you could fix it I shouldn't say fix it, but resolve it.
Sure,
maybe you can manage their symptoms, and maybe this is their new baseline norm. But those patients, I am still very confident in managing because I know what's going on.
Yeah. Okay.
The third bucket that I put people into, that I don't like to put them into, is on eval. I have your baselines, I have your comparables. I could not make any changes, and it's a complex presentation where I am not fully sure about what's going on. Yeah. There could be a few primary impairments, and I haven't narrowed it down to what the primary driver is for your symptoms. And that's where I think it goes down a couple of routes. It's like you do test, retest, and then you narrow it down to like one primary impairment. You treat that, and then it gets better. Boom, you fix them. The other times, it's usually you test, retest, you go through all of it, and you get nothing.
Okay.
No changes in their symptoms.
Right,
Still
gotcha.
have no idea what's going on.
Okay, and then is there like you find with any of these presentations you get a variable response? Maybe day one they had a significant change or reduction in symptoms with a certain direction of movement, and then they come in and they're like, oh, actually, it's a little bit worse. And then you try something different and they get better again. And then they come back and it's kind of all over the place. Do you find you see that presentation? And if so, how do you try to manage it? Let's say you've already established your baselines, all that's consistent. It's just the only thing with consistently variable is the symptomatic response to movement.
So I'm thinking of a couple of different cases. Like the first one that I mentioned is like there is no response. It stays the same. It's like maybe it's getting worse, but largely it's definitely not getting better. And so you've tried everything and nothing changes. And at that point, I'm just like, I have no idea what this could be. And then trying to troubleshoot that is definitely a challenge on its own. The other one that you mentioned, I've seen a handful of times, and it may be different to what you're talking about, but this is something that I've seen for spines for sure, where I have them go into extension, and I see that there is a directional preference, but it's not a full green light. It's just like it's better, but it's not selling me on that direction being true yet. Now, what usually happens is I've had patients where I've had to switch the direction, and they end up doing extensions, which majority of people will respond to. So that makes sense to start off with, especially if you're not sure if they have a directional preference one way or the other. You send them home with that, and they're like, "Oh, I feel better. It's definitely not worse. It's definitely better, but it's not like." And then they plateau. And then when they plateau, there have definitely been a couple of cases where I'm like, okay, their flexion is still limited. Their extension has plateaued, and now it's actually getting worse. Now their extension's giving me red lights. And so that's where I'm like, oh, this is really odd. And so I will actually start to flex them. And then sometimes the flexion becomes their new directional preference, or it gets things to move differently. And then once that hits another plateau, I return back to extension, and that fully resolves it. So the way that it was described to me was similar to like when you open up a drawer and it gets caught, you can't just shove it back in. Sometimes you have to pull the drawer out further before you can shimmy it, and then it goes back in smoothly once it gets on its tracks.
Cool. Okay. So you said maybe you have a little bit of a variable response. You have to switch it up a little bit just to get things back on track.
Sure.
Okay. Gotcha. How about you mentioned plateau? Like, you see, we can stick with spine. Like, let's say you have someone that has a directional preference to extension. If let's say they came to the first follow-up after the evaluation, they were 50% better. You went through your baselines, you retested. You found that same exact movement was still the correct movement to stick with. They come back for the second evaluation for visit 3, and they're still only 50% better. What's it look like when you are doing your follow-up evaluation? How are you retesting your baselines? Walk us through that a little bit.
So if I'm taking them through this, it's usually going to be okay. They're not changing. I have them retest right there without any other variability. They just do their comparable sign. From then, I have them do a round of the reductive motion that they're supposed to do for homework. Awesome. We do a round of that. I have them do their comparable sign again. Any change? If not, do one more round. Check again. Doesn't change, then I'll add more force. I'm going to progress that exercise in some way, shape, or form. And then we retest. So essentially, It is a bit more of a painstaking process, but you are essentially performing a mechanical exam every single time.
Yeah,
If they've plateaued, you kind of have to,
you have
because
to know. Yeah,
the only thing that you can really skip, arguably, is like, let's say on eval you get them um to patient overpressure, and then they
yeah,
respond with that. Most of the time you're gonna have to progress it. That's the only thing I
yeah,
would argue that you could probably skip. But other than that, like, you have to run through the entire thing to make sure that you're monitoring them correctly, and that this
yeah.
is like
Sure.
the right path that we're going down.
Yeah,
What
if
about
they're
you?
yeah,
What
no, for sure. I mean, like the reassessment, if the reassessment isn't consistent, if the order in which you're doing things, I mean, it doesn't have to be 100% the same way each time. I mean, when I do it, I typically is just I said I like the standardization, but especially in someone who's you think they're doing the right thing, but they've plateaued. That's two visits and they've plateaued. You gotta nail it down. You gotta know exactly what's happening, how it's responding. Yeah, just so you can alter the management so that they continue to improve. Yeah, if I get a plateau, I do look at we talked last time about the say like the hierarchy of like baseline measurements, impairments. Sorry, two episodes ago. So I'm looking at if they're plateauing in regards to like symptomatic response, but their movement is still improving and maybe their function's improving as well. I might stick with it for another visit before I start to add things. This is dependent on the symptom irritability, depending on the patient. If I know they can handle it and I'm really looking to get a really, really good understanding of what's going on, they have mild symptoms. I know if I give them a little bit more force that they'll be able to handle it. Yeah, I'll jump to it there. Um, but yeah, like if I'm getting some kind of change, maybe I give it another session. But yeah, what it really comes down to is just making the reassessment consistent, really knowing what's going on, and then understanding when you're going to begin to progress and when it's necessary. But yeah, sometimes as it depends on the patient. Sometimes I'm a little bit more conservative of when I'm progressing things, especially if they had like a significant improvement within a previous visit. Okay, maybe I do give it another week. But if it's like low symptom irritability and it's been like one or two visits and it's still not changing in any way, yeah, we got to do something more. Something has to change.
Sure, sure. And I know that we've talked quite a little bit about
Hmm.
spine
Yeah.
for this episode. For the people who are listening, this is the some of the verbiage that Mark and I are using do come from the MDT school of thought. So we'll touch a little bit more about this in regards to the mechanical exam and directional preference and different types of verbiage that we used here in a future episode. But essentially, when we talk about these things, a mechanical exam is just a movement screen that we're taking our patients through to determine if there's like any reproduction of their symptoms, any changes in regards to their symptoms and stuff like that. So that's typically what we do to just make sure that we get our baselines down as we continue to move through the rest of the exam. And when we talk about forces, all we're talking about here is just like the force progression that that MDT usually will default to in regards to knowing how exactly to dose our exercises, as well as what specific exercises to give to our specific patient. Is there anything else that you want to add in regards to that, Mark, or did I kind of
Yeah, yeah,
cover
you
those
definitely summed it up.
definitions?
I mean, if anyone's interested right now, I mean, you can Google it, go on their website, they have an explanation of the terms. But yeah, essentially what it comes down to is just, the terms that, like you said, we're using are terms that um, MDT will use just to describe the kind of exercise that's being prescribed and the amount of force that is being given during that exercise. But how about we had some spine examples that we talked about. Let's go to extremity. Like, what's it look like? Let's say it's not a quick responder. Let's say it's someone that's coming in. You're thinking it's more of like a soft tissue a contractile, dysfunction type thing, maybe even like a tendinopathy, what do your follow-ups look like when it's someone who at the initial evaluation you think that, it's going to take maybe even months for this person to start to respond, right? Not even saying that they're going to fully resolve within that amount of time, but you think it's going to take, um, you know, that maybe even like 1, 2, 3 months before they start to notice a reduction in symptoms.
Yeah, that is definitely a hard conversation to have.
Yeah,
Depending on um what their goals are. So for a lot of people, they're okay with slow and steady progress because they've usually been dealing with this issue for several months, if not
sure.
years
Yeah,
already.
yeah, yeah,
So what's another couple of months to them? But the issue comes if they are someone who's particularly active, if they have a competition coming up or anything along the lines of that, that is a much different conversation that I'm having. And they are usually not okay
yeah,
with the response of that. And they usually will want some sort of magic to happen
yeah,
to
sure.
be able to take away their symptoms. And the hard part about that is, and I have to really be patient, but also like selective with my words when I try to educate them, is if you have a tendinopathy, essentially, it's like you had you see the end result of it, but you don't see all the stuff that accumulated and led up to the point of your uh the inflammation or what could potentially become a rupture. All you know is that it was working fine until it wasn't. And that is what you see. And then you're like, why? Well, why can't we just flip that switch back? Unfortunately, tendinopathies do not really work in that manner. They do not work as a switch. It is a progressionary thing that usually just gets worse if the tendon has not adjusted to your training demands. Connective tissue sucks
Mm,
when we talk about how quickly it adapts, or I guess how slowly it can
right.
adapt compared to muscles. So when people are on a crunch and they know that they need to, they have expectations being able to perform at a high level, I have to talk to them right away where I'm like, hey, listen, I don't know how fast this is going to resolve. Can I manage it to where you can perform? Maybe, maybe not. Will it get worse with your competition? Once again, maybe, maybe not. There's a pretty big likelihood that it does, especially if you heard it previously in another competition where that intensity is just higher, you know. So it is a lot harder to have that conversation and to manage those patients because you want to make sure that you load them appropriately and that you get them to their timeline. But sometimes you just have to be like, hey, this isn't happening. You have
Yeah,
to be realistic.
yeah. The expectations certainly have to be managed, right? I mean, you talked about. You have to have the conversation, right? It's not. You have to be confident in telling them that, hey, listen, this, or at least the way I word it, I'm like, hey, sometimes these can improve quickly. Typically, it takes some time, right? So you're setting an expectation off the bat. I mean, if you tell them, hey, this will be better in a month, it doesn't happen. I mean, they're not going to trust you anymore past that. If you tell them up front, hey, I don't know if this is going to take a couple weeks. Typically, this takes a couple months before we start to see results. People certainly seem to be more receptive to that, even though initially they're not going to like what they're hearing. But as long as you can explain the plan to them, what it looks like going forward, and then what they can expect in the future, I think you can be on the same page, and they can, your relationship with this individual, um, can develop and help with the plan going forward. The one thing I typically do differently in regards to the reassessment, the follow up appointments. I'm still checking baselines. I'm still looking at what their range of motion strength, functional deficits looks like. I'm not expecting a rapid change unless they had one at the eval, but that's a different patient population there. So I'm still retesting things. In terms of like the frequency of the appointments, I'm typically spacing them out a little bit more. Maybe for the first week or two, I'll see them every week, but then past that, maybe every 2-3 weeks. Yeah, especially if I think this is something that's going to take months. But, compared to our quicker responders, which we talked about early in the episode, I'm not as concerned, or maybe even concerned at all, about any kind of change happening quickly in respond to movement. The conversation at the reassessments is typically, okay, how the exercise is going, how many reps are you doing? What's the external load look like, if there is any? If they're still continuing to train for whatever, it's running or lifting, whatever. Okay, how's that going? Are there any specific movements where you're noticing you're not able to, or you have increased symptoms for more than like a day after, right? Like, we're talking more about what their other training variables will look like and being able to manage that while they are managing the soft tissue dysfunction that they're presenting with, compared to if you have someone come in with that had a quick change at the eval. Then we're looking more at like, okay, symptom location, like we talked about earlier, the frequency, intensity, things like that. Where if we have more of a chronic soft tissue dysfunction presentation, the questioning is a little bit different.
Yeah, I feel like they are just very different presentations.
Yeah.
Completely,
Yeah.
and like the time frames, your expectations, setting your patient's expectations, even they are very different compared to like someone who is a quick responder versus someone who's like a slower responder. And they honestly very well could be the same pathology, like some spines you treat and they're like, oh, that's gone. You're done within that session and that's it. Other ones take months for them to actually see and get like significant progress. Maybe they needed an injection, maybe they needed time, maybe they needed a whole bunch of other lifestyle factors to be addressed before they notice that improvement. And then talking about tendinopathies, I've seen tendinopathies that I don't want to say resolve, but they certainly respond within that first visit. Where if they're a lower irritability, you give them a couple of isometrics, it calms down, and they're like, oh, that feels a whole lot better. Awesome, you're on the right track. Fantastic. Then you have other tendinopathies that just will not respond whatsoever, and they take a much longer time, and you need to be able to load that appropriately too. And that could be very frustrating for your patient and for you as the clinician. So I think it's important to kind of note that not all conditions are considered the same, even though they are the same condition. It's definitely specific to your patient and how they're presenting.
Yeah. And I mean, what's going to give you the information? Test, retest, right? I mean, like you talked about isometrics. Hey, if we're assuming this is like a chronic tendinopathy, it's not going to respond, and we don't, it's not, the load isn't managed correctly. We don't test some things out in the beginning. Hey, what happens if you do a couple heel raises? What if you hold at the top? What if you, right? And we don't gauge the symptomatic response, and we just assume, hey, it's, Achilles tendinopathy. This is what you're gonna do at home, and you're gonna, go to the step and drop it off, whatever kind of thing you want to do. And we're not testing it within the clinic that first day, engaging the symptomatic response. I mean, even if it doesn't change symptomatically, I think that management is poor anyway. But like what you said, sometimes people come in, hey, I have this pain. It's right where, this tendon goes to my heel, or maybe it's like the middle of the tendon. Screen spine, nothing. You start to load them up. You ask for their symptomatic response. Hey, actually, it feels better. Okay, here, go jump up and down a couple times. Oh yeah, really, it hurts like 75% less compared to when I did it, yesterday. We wouldn't know unless we reevaluated it.
Now, the one thing that I want to add to that, and when we're testing symptomatic response, there is certainly the possibility that we can flare someone up or that we just make their symptoms worse. It happens. That's kind of the nature of this, is because we need to derive a lot more information from the patient and what they can possibly give us, because they don't know how to test themselves out, really. They may have like a little bit of an understanding, but they won't know to what extent to do it compared to like us as clinicians, right? But the one thing that I'll say is, almost every single patient that I do this on, even if they leave and they're like, "Oh, I'm worse than before, or I'm hurting," is I almost always will be like, "I'm sorry, it's just part of the process. And I promise not to beat you up so much next time." You do it once, so that way you get the information you need so you can make the appropriate decision and not have to go back again. The hard part is, if you don't do that, you won't know what to do going forward. And you very well could flare them up, just because, like Mark said, you don't know what their symptom presentation is going to be if you haven't tested them under a load or under a volume that you've prescribed for them. So you might as well make that mistake, or not even a mistake, but get that, kind of flare them up in a way, like maybe you don't intend on it happening, but at least do it within your care so you can see for yourself what happens. How is it going to change? How quickly does it change? And then if there's something that you can do to help reverse that, that's even better. But you don't always have that option. But it's nice for you to have all that information. And almost every single time, whenever that happens, my patient is just like, "Oh, totally get it. It's just part of the process. I understand. This is what you have to do." I think I can count, like, I remember only one person, because it's so it stands out, where they're like, "Oh my God, I'm worse. Why did you do this to me?" And I'm just like, "Sorry, but I kind of have to, And then they get it down the road, but it's just one of those things where most people will understand. Do not be gun shy when it comes to this kind of stuff. You need the information. That is like, the best thing you can do to care for your patients.
Yeah, especially the chronic presentations. Like, it's been going on for, whatever amount of time. If they have a couple days where it's more sore, and now you know where their top end is, and now you have a better idea of like what their load management strategy, or how you're going to implement the load management strategy is going forward. I mean, that's necessary information. That, we'll deal with a couple days of some increased soreness, especially if it's something that's been going on for a long time, right? We can deal with that. Hey, good, we got this information. Now we know where to go going forward. So how do you know? Let's talk about, if you want anything to add for that.
Oh, I was gonna ask you, on the topic of soreness, what do you do when you talk to patients, or when they're like, they come in for their, like, usually, at least for me, it's their second follow-up, and they're like, "Oh my God, I was so sore. Like, I can't do that exercise again," or anything along the lines of that. Like, I usually will give them a heads up, like, "Hey, there's a chance that you could be sore for the next day or two. It's very likely like ripping off a Band-Aid. The first time where you're sore, it happens, it sucks, but the next time it won't be nearly as bad. Your body just adapts to it so quickly." What do you typically do, or what do you educate your patients on when something like that happens?
Yeah, I try my best to get ahead of it. So especially if it's, let's say, spine patient, let's say, someone who's centralizing, but, the movement they're doing, they're not used to doing, every couple hours, 10, 15 reps, whatever. Obviously, we can expect some kind of, soreness, localized spine soreness, maybe even some pain due to the movement. So I try to get ahead of it. Like, listen, you did this movement today. Your symptoms came out of your leg. Maybe you're feeling more sore in the back, which is normal. May even feel more sore as you keep doing this, but you got to keep monitoring the leg symptoms. I try and get ahead of it as best I can. If they understand that, I mean, sometimes I do have people that come back and they're like, "Oh no, my leg's fine, just my back really hurts," and they're a little bit resistant to continue doing the same movement. Okay, maybe we're at the point we can taper off the volume, and this kind of brings us to the next topic I wanted to cover, is when when should you progress? When should you change things. Maybe you have to regress at some point. So this specific, if someone's really resistant to doing a certain movement, but they're still improving, they say, even if they say it's not improving, right? Oh, my back hurts more, my leg doesn't hurt. Right? If I can tell they're improving, okay, I'll work with them a little bit. Okay, hey, just do it half as much. Actually, take a couple days off, see how you feel. They come back in a couple days. Yeah, actually, my back's feeling better, and my leg, it hasn't been, numb. Okay, cool. Now we can start to work with that. Versus if they came in and I just came down on them and said, no, you got to keep doing this exercise. You got to keep doing it, blah, blah, blah. Yeah, maybe they still get better. I mean, maybe they cancel all their appointments. Maybe they leave right there, right? So, there's got to be a little bit of leeway, right? There's got to be something. We have to kind of find some kind of middle ground between what we think is going to be the best management for them and what they're feeling as well. So yeah, I try my best to get ahead of it. If I explain that centralization phenomenon to them, and that, hey, you might have some more pain in the spine, but I want you to keep in mind, what you're feeling in the back of your leg. If people come back and like, hey, usually like, oh, hey, you were right. Like, actually, my back's kind of sore, and it was sore for a couple of days after, but actually, my leg's better, and the back's not as sore. Yeah, I find that I experience that more often than someone coming in saying, hey, I'm not doing that exercise anymore. It hurts too much. And this isn't the case that the person is improving, at least from my standpoint. I'm trying to think of any other kind of presentations of that. Yeah, not too much. I think the bottom line comes down to, okay, talking to your patient, getting their point of view, and then come to middle ground, especially if they're really resistant. Some people come in and they're like, oh, I was more sore for a couple of days, but now it's better. Is that how it's supposed to be? Maybe depending on the presentation. So some people are more open, some people are a little bit more closed off to whatever the recommendation is. It's all about, like I said, getting the middle ground, working with your patient so you can find a plan that's going to work for them specifically.
Yeah, I find that for patients, when it comes to discussing soreness with them, this happens, like, it's so interesting because people really do struggle to know what is painful and what is sore or what is fatigue, and things along that line. So I really have to, like, clarify with them where I'm like, hey, I'm okay with soreness. Soreness is fine. I'm okay with it being worked or it being tired. That's totally fine.
Some people pain just say that's different. Pain. Yeah, they're like, you have them do a knee extension and like, oh, that hurts. Where? And they point to their quad. And they're like, all right, is it painful or you're just using that muscle? Oh, yeah, it's just a muscle. Well, yeah, it's the clarification is certainly necessary, right? Like you were saying.
Yeah, so I think that teaching them that is super important. But the other thing is, and I didn't put much into this, but I only started to do it like a few months ago, because a couple of patients would be like, oh, I was so sore, I couldn't do anything at all. And I was like, if you're really sore, one of the best things that you could do is to just move around a little bit, So if they come in and they're super sore, I will actually have them just like do a couple of the motions that we did previously that made them sore, but just to a lesser degree. And I actually feel better now. I'm like, that's usually what's going to happen.
Right, maybe 5 reps instead of 10, maybe cut down a set or so. Yeah, right. Just, hey, work into it a little bit. Oh, yeah, it's not as bad. Right. And now they can take that information home with them. Right. Okay, cool. My leg's a little bit sore today. If I, bend it, straighten it a little bit, do a couple, stand up, sit down. Oh yeah, it's not as bad. Which, some people just don't, they don't have, maybe they haven't exercised before. Maybe their perception of like pain and soreness is a little bit different. Yeah. Then, especially that patient presentation, like your follow-ups, your reassessment, they're a little bit more education based. You're teaching them, the benefits that movement can have versus, your quick responder that could see an immediate benefit, right? You're altering your reassessments. It's different.
Sure. So, on the topic of soreness and whatnot, when do you know that you should progress someone? Because I feel like sore, like they're going to be sore the first time. I'm probably not going to progress them that session immediately. I'm, if anything, I might just increase, like I'll probably keep their reps relatively the same. I may increase their reps for some things, but other than that, it's nothing like major in regards to their progression. But like, how do you know like when you should really change something and up the difficulty, not just by like 1 or 2 reps, not by like a couple of pounds, but like really continuing to push them? What are your like metrics, or what do you use to kind of determine that?
Yeah, I mean, and when we're talking about the slower responder chronic type patient, correct?
Yes.
Yeah. So, and maybe this is something I should be doing better at. I don't have any specific like quantitative measures I use. I guess I could use like RPE, something like that. But the main thing I'm looking for is if it's pain that's limiting the patient, I can ask them subjectively, okay, how'd your first rep feel? How did the 15th rep feel? If they tell me, oh yeah, by the last rep, I didn't have any pain. To me, okay, hey, maybe we can handle a little bit more load. Especially if their first rep, hey, it didn't hurt that much, and then at the end it didn't hurt at all. Okay, we can do a little bit more, right? We can add some resistance. We can maybe tack a set on. We can add some reps. Another thing I look for is what their symptoms are looking like afterwards. If someone, is doing a certain exercise and let's say they didn't have any pain to start, but after, they're sitting at like a 5 out of 10 for like 4 or 5 minutes. All right, maybe I have to regress. On the other hand, if someone had, let's say, 2 out of 10 to start, they did the entire set and they felt a 2 out of 10 the entire time, and it was still a 2 out of 10 afterwards. Okay, maybe we can start to push it a little bit, right? So I'm looking, especially if pain's like the limiting factor, I'm looking at the symptomatic response. If we're staying the same through the set and it's not like mid-high grade pain, okay, maybe we can tolerate a little bit more. If their pain improves through the set, okay, certainly we could probably tolerate a little bit more. If it's worse afterwards, or it's worse as they continue and it stays worse afterwards, maybe we're cutting it down a little. When it comes to fatigue, that's where I don't quantify as much. Maybe I'll ask the person, like if they get to the last rep, hey, you feel like you could have done another like 2 reps? You feel like you could have done 5 more, right? If they're like, oh, there's no way. All right, maybe I scale down. It depends on this one gets a little bit trickier too. Pain, I feel like people get an idea of like what they can handle. When it comes to fatigue and stuff, especially if it's a individual who isn't used to exercising, understand what it's supposed to feel like, they might stop at like RPE 3. Like they're just like gonna, oh yeah, it starts to get hard, so they just stop, right? It's like, I don't know, it's hard to get a good quantitative measure for that, in my opinion. Dude, honestly, sometimes they come in, let's say we're doing leg press. I'm just gonna throw another 10 pounds on there and see how they do with it, right? I mean, they're probably not looking at the weight. And then they just do it. I'm like, cool, they did 10 more, right? And I'll tell them, hey, you did 120 today. You've been doing 110 like the last like week or two. I'm like, oh, that didn't feel too bad. Okay, cool, right? So yeah, I don't have a good answer when it comes to the fatigue aspect. But when it comes to pain, like I said, I'm looking at how their symptoms, how they start, if they change throughout the set, and then what we're looking like afterwards. Do you follow any kind of, do you quantify these, how do you know the progress? Do you follow any kind of quantitative metric, or you have your own kind of method?
Yeah, so I really do. I took this from like what I use for my own clients when I train them is I use a double progression, which is like when you hit the top end of your rep range for however many prescribed sets, then you add more load and you regress the volume. That is typically how I do things. It just makes it a lot easier. It kind of dummy proofs it a lot of times for people, and they don't have to think as much in regards to it. Sure, there are some downfalls, but that's a topic for another day.
Yeah.
But when I use it in the clinic, I will do virtually the same thing. I will give patients a range for their reps. We already knew what they could do previously, and then I will almost always check in and see easy, medium, or hard. And if it's easy, definitely bumping up the load. If it's medium to hard, I make changes depending on the volume. So if it's medium and I know that there's someone who pushes pretty hard, I'll probably give them somewhere between like 10 to 15. If it's hard for them already, I'm much more likely to give them maybe 6 to 10, depending on like what the exercise is.
Yeah. When you said range, are you talking? So is this the range talking about the sets and reps, or like will you? And do you explicitly state it to the patient? I want you to do, at least 6, but not more than 10, or is this a range that you're like going through in your head?
Oh, so I actually tell them. So I'll usually say,
gotcha.
Give me 10 to 15, 3 rounds. Do whatever you think you can do.
Okay, cool. Yeah.
And so I'll track that. And so like if I notice that they are only doing the bottom end of the rep range, maybe instead of 10 to 15, I say 12 to 15. And then after that it becomes 15 to 20, and then so on and so forth. And then I just automatically will bump them up as they continue to progress in their volume.
Gotcha.
So that's typically how I progress patients in regards to like how they're doing there. The other thing that I find to be kind of hysterical is the unique nature of my clinic means that I will have to cover for someone else's patient pretty often. And one of the ways that you can make a leg press hard or harder is by changing the depth or the seat position. Mm-hmm. So if I am covering someone who has like a total knee, total hip, anything like that, one of the things that I typically will do is I will bump the seat up to make sure that they're getting as much flexion as they can. And then I watch their weight absolutely plummet. And I'm like, oh, okay. So you haven't been going as far down.
Yeah.
And so now we see this. Now we can adjust your weight accordingly. And I track their seat position now and see, oh, okay, you can do this weight at this seat position. This seat position no longer changes. The weight is going to change, and so are your reps, but this should not change. And so in doing that with my own total joint replacements, I've seen significant improvements and a lot more consistency because I can track to see how much they can tolerate that loaded flexion. And if we can continue to improve on that, because that's one of the harder parts for them is that bottom position and getting out of it. It's why people struggle to get out of a squat position so much. But those are like a few ways that I've really found to progress patients, at least using like some quantifiable metrics that just make it a lot easier for me to track and notice. Like, oh, we're definitely getting better here.
Yeah, the range of motion is a good point. Like you said, I mean, maybe there's a reason someone's doing a leg press at like 50 degrees of knee flexion, but especially when you talk functionally, getting up on a chair, getting up from the floor. Yeah, it's going to be from a higher degree, or at least like a mid-range, usually a higher mid-range degree of knee flexions, but also a quantitative way that you can progress people.
Yeah, for sure. I feel like it's just something that tends to go overlooked. I feel like when most people put their patients, at least from what I've seen on the leg press, it is almost always like above 90 degrees. Yeah. Maybe you're getting to 90, but it is severely underloaded in regards to both the range and the weight. And one of the things that like this is my biggest gripe with the leg press is when you squat, you are squatting your full body weight. Even if you use a TRX and it's upper extremity assisted, you're still squatting. Let's be generous and say that the TRX knocks off like 25% of your body weight. Like if you're leg pressing like 60, 70 pounds, what is that actually gonna do for your extremity? Like it's not doing a whole lot. So to me, it's just like you really, really should be loading them a whole lot more when it comes to stuff like this.
All right. Anyone listening who's got a family member that don't go to Kane's clinic, all right? You're gonna be like, just get them ready for the leg press. Cool. All right, perfect. Anything else you want to add?
No, I think that we covered a whole lot of stuff in regards to like what we look for in follow-up treatments, and then what we kind of do moving forward with our treatments in regards to carrying out our plan of care, and then just making sure that everything is going according to plan. What about you, Mark? Anything else that you want to add?
I think we still like this hallmark feature we talk about, the test retest, like it stays consistent regardless of, well, it changes, but you're still doing it regardless of your patient population. You got to know if they're improving, you got to know how they're improving, in what aspects they're improving, and it's just going to help guide your plan of care better. So we talked about our group of quick rapid responders, right? Which you have a good idea of what's going on at the eval. They come for their reassessment, their follow-up. You check their baselines. They're telling you they're better. You can see that they're better. All right, pretty simple. Next group, people who are still responding. Maybe it's not as, the response isn't as consistent. Maybe it's a slight improvement, and just need to make sure that that's going to continue over time. So your reassessments maybe even a little bit more specific than your quick responder, right? You're checking your baselines, you're checking their exercise, their movements, and you're really nailing down, okay, this is consistently improving. We see at each follow-up, even though it's slow, it should continue. And it's your job to make sure that the patient's, doing their part. And then your reassessment is going to continue to guide you to make sure that the management is still appropriate going forward. Our third and final group, maybe people who are going to take months, right? Maybe we talk about chronic type conditions, tendinopathy, soft tissue, this contractile dysfunctions, things like that. All right, their expectations have to be set at the beginning. Maybe you're still looking at baselines, you're still checking response to movement, but it's in a different way. But regardless of the patient in front of you, the reassessment's still important. Your test retest is still there. It's for you to utilize. It's going to give you the information you need to manage patients appropriately. Thank you for listening, everyone. We hope you enjoyed this episode of the PT Good Podcast. Remember to leave us a like and subscribe to us on whatever platform you're listening to us on, and we'll see you on the next episode.
I still love you. Bye.